If you're a woman on hormone therapy right now, patch, gel, cream, pill, etc., there's a very good chance that you're only taking one estrogen. But did you know that your body actually made three? Nobody's ever run a study showing that one is good enough. And a few weeks ago, a physician with a large following made a video about me pointing that out. Not by name, but about this, about that the one estrogen that was left out, and that estrogen is called estriol. Her message was this is settled. Estradiol is enough, and stop confusing women. She brought a citation list, which honestly, I truly respect. And that's how this work is supposed to be. So if you know me, I read them. I read every one of them. And one of the strongest studies on the list cited as proof that estradiol reduces inflammation. But it used a hormone preparation that was 80% estriol, plus progesterone, plus DHEA, plus testosterone. So she actually cited an estriol study to argue against estriol. Another one on the list studied transgender women taking estradiol along with an anti-androgen. And the authors say in their own limitation section that they could not separate the effect of the estradiol from the effect of the other drug. They said that, and that was actually in the paper. And a third one, the title of the paper is literally about estrogen's opposing effects, meaning sometimes it inflames, sometimes it calms, depending on the context. And that was cited as proof that estrogen actually can calm. And I'm not telling you this to embarrass anybody. I'm telling you because if the people declaring this conversation is over haven't read their own evidence, then the conversation really is not over. So today we're going to talk estriol, the third estrogen, the one your body made every month of your reproductive life. That's almost certainly not in your prescription, that most of your providers were honestly never taught about, and honestly, nobody on earth can really make money on. What it does, what the receptor science actually shows, why it disappeared, and what to ask your doctor. So let's get into it. So before I go another sentence further, I think there's some things you need to know about me. I own a compounding pharmacy, and we make biased. If a woman fills a biased prescription, that's estriol and estradiol, instead of picking up a patch at a chain, as a compounding pharmacist, that's how I make a living. And you should know that. And you should also weigh that against everything else that I'm going to talk to you about the next half hour. And honestly, I don't really care where you fill your prescription. Fill it down the street, fill it at another state, fill it at another pharmacy. I don't care if I've ever heard of that pharmacy before. I'm doing this because women deserve the full conversation. And right now, most of them just honestly aren't getting that. I've been making this argument for 20 years, long before there was a patch shortage and sending anybody to the pharmacy down the street. And one more thing you should know before we start. Every study I reference today is in the show notes. Author, journal, year, and PubMed ID number so that you can pull it yourself in about 10 seconds. And go read them. Go read them before you argue with me, and go read them before you agree with me. That's the standard I'm holding myself to for the next half hour. And after that cold open, I hope you understand why. So why did estriol vanish? And here's the question that I want you to be thinking about. Your body makes three estrogens: estrone, estradiol, and estriol. Every hormone therapy prescription written in this country replaces one of them. Why? The answer is not that somebody studied estriol and found it to be useless. The answer is much more boring than that, but actually much worse. Estriol is a molecule that your body already makes. You can't patent it. And if you cannot patent it, no pharmaceutical company is going to spend $200 million running trials required to bring it to market, because at the end of that process, anybody could make it. So there's no commercial estriol product in the United States. And that's one fact that just cascades. No product means no sales rep sitting in a waiting room explaining it. No sales rep means it's not in the continuation education dinner for your medical provider. It's not at the residency lecture. It's not even in the pharmacy school curriculum. I went to pharmacy school, and I can tell you exactly how many times and how many lectures were spent on estriol. Almost none. And because it never enters the training pipeline, it really never enters the guidelines. And because it's not in the guidelines, a careful, conscientious physician who has done everything right will never prescribe it. Not because she evaluated it and rejected it, it's because she really never encountered it. Estriol, it didn't lose a scientific argument. It lost a business argument, and then we mistook the silence for a verdict. And here's the part that I find almost funny. Right now at Ohio State, UCLA, researchers are building synthetic drugs designed to hit the estrogen receptor beta selectively. That's the receptor we're going to spend most of this episode on. And there are compounds in preclinical development with more than 100-fold selectivity for that receptor. They're being studied for multiple sclerosis, for neurodegeneration, and even for inflammation. The entire scientific rationale for building these drugs is that the receptor beta does things that nothing currently approved does well. They're right. And your body already made a molecule that prefers that receptor, and that's called estriol. They just can't patent it, so they're building synthetic versions of something that can be used that honestly your body produced every single month. So estrogen doesn't just do one thing in the body. It does whatever the receptor it lands on tells it to do. And before somebody in the comments beats me to it, there are more than 2 ways your body responds to estrogen. There are 2 classical nuclear receptors. That's alpha and beta. There's also membrane receptors. These are G protein receptors that handle much faster signaling on a different time scale. Those are real, and those also matter. But when you look at decades of data on things like bone, breast, brain, gut, immune function, the load-bearing evidence sets on alpha and beta, and that's where I'm going to stay today. So the 2 main estrogen receptors are alpha and beta. They are not 2 versions of the same switch, and they frequently do opposite things. Receptor alpha broadly drives growth, cell proliferation. It's a receptor behind a lot of what hormone therapy focuses on and is famous for. Things like controlling hot flashes, maintaining bone density, and supporting cardiovascular health. Real benefits. And I want to be super clear about that because I am not here to talk you out of using estradiol. Receptor beta tends to do the opposite. It restrains growth. It quiets inflammation. It shows up heavily in tissues that need maintenance and calmer rather than proliferation. Your brain, your gut lining, your immune cells, and your ureteral general tissue. Alpha builds, beta protects, and you need both, and they are not interchangeable. Now, estradiol, the hormone that's in your patch, your gel, or your cream, binds both of these receptors, and it binds them with roughly equal strength. And the single most common argument that I get, if estradiol binds both receptors, you're covered. Why would you need anything else? And here's why. And this is the sentence I want you to take out of this episode if you're not going to take anything else. Binding is not activation. A key that fits the lock is not the same as the key that turns it. Estradiol binds receptor beta perfectly well. What it doesn't do is drive it the same way it drives receptor alpha. In the transcription work where somebody measured both the binding and the actual gene activity that followed the binding, estradiol produced about 1/5 of the output at the receptor beta that it produced at receptor alpha. Same molecule, same concentration. In that system, a fraction of the effect. Now that's one essay, and I'll say this before anybody else says it to me, but the structural biology explains exactly why you would expect this. Receptor beta is missing part of the machinery that receptor alpha uses to fully switch on. There's a partner protein that receptor alpha recruits to get both of its activation domains cooperating. Receptor beta actually can't recruit it. So only half of the activation apparatus is available. And that's not an artifact of one experiment. That's the architecture of the estrogen receptor beta. And here's where it gets a little stranger. Crystal structure work showed that when estradiol sits on receptor beta, it can push a piece of the receptor that determines the on and off into the off position. Not partially on, but off, which means that some fraction of the estradiol sitting on receptor beta is occupying it while it's producing nothing. So remember, binding is occupancy, but activation is output. These are the 2 different measurements. And the field of experts out there keep quoting the first one as if it settles the second. Now let's bring in the other molecule. Estriol is a weaker estrogen overall than estradiol. That's true. And I'll come back to why that's a feature and not a bug. But what matters isn't how strong it is, it's where it leans. There's a study that measured the binding affinity for 74 different estrogen metabolites against both receptors. That's 74. That's the most complete map that we have at this point. And in the work, Estriol showed a clear preference for estrogen beta over receptor alpha. Depending on the conditions, this can be anywhere between 10 to 18-fold. So when I say Estriol is beta preferring, that's what I mean. Not that it ignores receptor alpha. It's that it leans towards the receptor that estradiol underperforms at. Estradiol is the master key that fits receptor alpha perfectly and receptor beta poorly. Now, estriol is the specialist that goes where the estradiol underperforms. And here's one more thing, and it matters to a lot of you. When your cholesterol runs high, your body produces more of a cholesterol byproduct called 27-hydroxycholesterol. You don't need to remember the name, but here's what you do need to remember. It interferes with estradiol's ability to signal at receptor beta specifically, with more than 100-fold preference for interfering there rather than receptor alpha. So the exact woman who needs receptor beta support the most, that's a woman who has metabolic syndrome, elevated cholesterol, or even extra weight around that middle. Their own physiology is putting additional pressure on estradiol's already weak access to that same beta receptor. So now let's talk about where not having enough estriol really can show up. Stop one, your serotonin factory. Deep in your brainstem, there's a small region called the dorsal raphe nucleus. It's where most of your body's serotonin is manufactured. And at that region, it specifically expresses receptor beta essentially almost exclusively. There's no meaningful receptor alpha there to really work with. In animal work, which researchers knocked out receptor beta, the serotonin producing neurons in that region declined markedly. A receptor beta selective agonist maintained them. But you know what? Estradiol, it didn't. And here's the finding that really shocked me. Researchers modeled late menopause, long after ovarian failure ended, and they tested both. At that point, estradiol had lost its antidepressant effect almost entirely, but the receptor beta compound, it even still worked then. So there is a window when estradiol stops helping mood. The receptor beta pathway is still open even after that previous window closes. If you're a woman on hormone therapy whose hot flashes resolve beautifully and whose mood, anxiety, and sleep do not, you may have been told your hormones look fine. And you know what? Your hormones may look fine. The question is which receptor your symptoms are truly running on. Stop 2 is your memory. Same principle, different tissue. It's in the hippocampus of your brain. This is the seat of your memory formation. A beta receptor selective compound increased the structural proteins that synapses are built from, enhanced the electrical process underlying your memory formation, and increased branching and between the neurons, and this improved the performance on memory tasks. Now, a receptor alpha selective compound tested head-to-head did not improve memory performance. And yes, this is animal work, and so I'll say it plainly rather than have somebody else say it to me, but look at how this lines up. The brain regions where women report the most cognitive change during menopause are disproportionately receptor beta regions. And we're replacing the estrogen that serves receptor beta the most poor. Every woman that's been told by her doctor that her memory changed after menopause and been told her estrogen looks fine deserves to know that the memory forming part of her brain runs on the receptor that her traditional prescription probably barely reaches. Stop 3 is your gut. Did you know your entire GI tract from your small intestine through your colon is dominated by receptor beta? Receptor alpha is barely expressed here. Receptor beta maintains the tight junctions. That's the seals between the cell linings in your gut wall. And when signaling drops, those seals loosen and permeability increases. That's the big part of what people are describing when they say leaky gut. And it's a receptor level mechanism, not a wellness slogan. And there's a loop here that I don't really hear anybody talking about. The bacteria in your gut regulate how much active estrogen recirculates in your body. And when your gut barrier degrades and the bacterial population shifts, circulating estrogen actually drops further. Now, less estrogen means weaker receptor beta signaling in your gut. Weaker signaling means more permeability. And that loop, it just feeds itself. And that estradiol patch doesn't break it because the patch isn't reaching the receptor effectively in the first place. Now, the study that I would point to if I only had one, researchers took colonic tissue and compared 3 things directly side by side. Estradiols at concentrations matching standard replacement doses, a receptor alpha selective compound, and a receptor beta selective compound. In that experiment, estradiol didn't reduce cell proliferation. The alpha selective compound didn't reduce it either. Only the beta selective compound did, and the same pattern held across the other endpoints that they measured. So in that colon model, tissues where receptor beta is the dominant player, estradiol at replacement range concentrations didn't move what that beta compound moved. And that's not my interpretation of anything. That's 3 arms of one experiment run side by side. Stop 4 is the immune system. Postmenopausal women shift into a measurably more inflamed states. And that's not just aging. We see things like inflammatory markers rise, the regulatory brake on the immune system often loosens, and there's even well-documented cases showing that the vaccine response of menopausal women disappears much during that time. So the obvious question is, does replacing estrogen actually fix that? A prospective study gave postmenopausal women estradiol for 14 to 17 weeks and then measured their immune system comprehensively. They looked at white cell subtypes, immunoglobulins, and a full panel of cytokines. Not one marker changed, not one. That's a study that I keep coming back to because it isn't a mechanism and it isn't an exploration. It's women given estradiol, measured before and after, and the immune system, it didn't move. And there's a receptor reason for that too. The immune cells types aren't uniform. Some of your T cells are receptor alpha heavy, while your B cells are receptor beta heavy. Estradiol preferentially binds and goes to one of those populations. A receptor beta preferring molecule reaches the other. And a quick stop 5, and the tissue that estriol is already standard. And I want to name this one because it's the one place, honestly, that nobody will argue with me. Vaginal and urogenital tissue is receptor beta rich. And vaginal estriol has been used for decades. A landmark New England Journal of Medicine study found that vaginal estriol reduced recurrent UTIs from about 6 infections per year to like a half an infection per year by restoring the tissue, restoring the protective bacteria, and bringing the pH back into range. Now, nobody calls this fringe. It's the urology guidelines. So we already accept that estriol does something real at receptor beta dominant tissues. So my question is just, why did we just decide that that stops at the vaginal wall? So what about human evidence? Now, if you've been listening carefully, I'm sure you're building lots of objection. Most of what I've described is receptor biology, deep science, and animal work, and that's fair. That objection is coming later in this episode, and I'm going to take that very seriously. But first, I want to show you what happens when you give estriol to actual human beings. A neurologist at UCLA noticed something clinicians had observed for decades. Women with multiple sclerosis often improve dramatically during pregnancy, then flare after delivery. Same pattern shows up in rheumatoid arthritis, in psoriasis, and also in thyroid disease. Estriol during pregnancy rises to a level about 1,000 times higher than normal. So she asked the obvious question nobody had tested. What if we gave estriol to women who aren't pregnant? 10 women with relapsing, remitting multiple sclerosis. Oral estriol, the inflammatory brain lesions on the MRI dropped by more than 70%. Then she stopped the estriol. Those lesions, they came back. She then restarted it, and they went down again. On, off, on. That design is about as close as a clinical medicine can get to proving causation. The effect tracked the hormone. The immune data from that trial showed the same pattern. Anti-inflammatory signals went up. TNF-alpha, one of the primary drivers of chronic inflammation, went down. Stop the estriol, it reversed. Restart it, this same pattern returned. Then it went further. A multi-center randomized placebo-controlled phase 2 trial. 164 women across 16 sites. Estriol added to standard therapy reduced the relapse rates by roughly 1/3 to 1/2. Cognitive function, it improved in women with the highest estriol levels. And what I want you to notice is who funded this trial. Not a pharmaceutical company, but the NIH and the National Multiple Sclerosis Society. Now, those are women with multiple sclerosis at higher doses than we use for hormone therapy. Somebody will tell you that this means that this information doesn't transfer. What it actually means is that we know that estriol produces measurable immune effects in living human beings, and we know roughly where the dose response starts. That's not a limitation. That's information that we don't have for most of what gets prescribed confidently every day. Here's what will not go away. Give women estradiol, measure their immune systems, nothing moves. Give women estriol, measure the same biology. It moves, it reverses when you stop, and it returns when you restart. 2 sets of humans, 2 molecules, but 2 completely different results. Now, that is not receptor theory anymore. This is outcome data that people keep telling me that truly doesn't exist. Time for a segment that I do in many of my shows. It's called Sounds Good, Is It True? Here's the claim, and this is the single most common thing said to me on this topic, usually by people with really good credentials. Estradiol binds both receptors, so you're already covered. Why do you need both? Sounds good. It's even half true. The binding part is accurate, and I said so earlier. And here's why it isn't true. Binding is occupancy, but activation is output. Where researchers measured the output, estradiol drove the receptor beta in a fraction of what it drove receptor alpha. The receptor is structurally missing a part of the machinery that it would need. Estradiol can actually lock it in the opposition, and if your cholesterol is also elevated, your own metabolism is interfering with the access that it has. Meanwhile, in the tissue test where somebody actually checked the colon, the serotonin system, and your immune panel, estradiol produced the effect you'd predict from biology, which is to say, not much. So sitting in the driver's seat isn't the same thing as driving. That's the difference between binding and activating, and that is the whole argument. Okay, now I want to do something that I don't see people do enough, and I'm going to read you the best arguments against everything I just told you, not the weak ones, the strong ones, in their own words, and then I'm going to answer them. So there's a physician that wrote me this word for word. Mechanisms generate hypotheses. They don't establish clinical benefit. That's a real principle, and I agree with it. Receptor affinity doesn't automatically translate into clinical results. Receptor density matters, local metabolism matters, and concentration matters. But watch what happens when you apply this principle evenly. Where's the randomized controlled trial showing that replacing one of a woman's 3 estrogens is sufficient? Show me the study where they gave one group estradiol alone, another group estradiol plus estriol, followed them for years, and found no difference. Guess what? It doesn't exist, and nobody's ever ran that. Estradiol alone isn't an evidence-based conclusion. It's default. It became the standard because it's the only estrogen a company could sell, and then 30 years later passed and everyone forgot it was really ever just a choice. So if mechanism isn't enough to justify adding estriol, then the mechanism isn't enough to justify leaving it out either. Right now, the entire standard of care rests on an assumption that really nobody's tested. And I'm the only one that's being asked for trials. The default should be asked for in the same thing. And there's a reason that those trials don't exist. And it's the same reason that I mentioned at the top of the episode. Nobody funds a trial for a molecule nobody can own. Absence of evidence when nobody has a financial reason to generate evidence is not evidence of absence. It's evidence of a funding structure problem. And here's an argument that nobody has thrown at me yet, so I'll throw it at myself. The most famous case in modern medicine for mechanism being overturned by a trial is estrogen and heart disease. We had the mechanism, we had the observational data, then the Women's Health Initiative ran the trial and the field was upside down for 20 years. Millions of women were pulled off their hormone therapy that was actually helping them. So doesn't history argue against everything that I'm saying? No, it argues for it. And I want you to see why, because this is the whole point of this episode. That trial tested one specific drug, conjugated equine estrogen, horse estrogen, plus a synthetic progestin in women averaging more than a decade past menopause. And the field took that one result and applied it to every estrogen, every route, every woman for 2 decades. Women's Health Initiative wasn't a failure of mechanism. It was a failure to read carefully. The field said estrogen when it meant one specific molecule in one specific population. And women, they have paid for that imprecision for 20 years. And we're doing the exact same thing right now, just pointed out in the other direction. When somebody tells you the science on estrogen replacement is settled, ask them which estrogen. Because if the answer is a category instead of a molecule, then honestly, we haven't learned anything. And one correction while I'm here, because precision is the whole argument. The colorectal cancer reduction seen in the trial came from conjugated equine estrogen with a progestin, not from estriol. Anybody using that finding to support estriol is doing the same sloppy thing that I've been complaining about the last half hour. My colon evidence is a head-to-head receptor comparison work, and it doesn't need that trial. And finally, this is the best argument that anyone has made against me, and it deserves a real answer rather than a dodge. Estriol is a weaker estrogen. Put a weaker molecule and a stronger molecule in the same body, and the weak one occupies the receptor the strong one wanted. So aren't you blunting the estradiol that you're paying for? Good pharmacology. And the answer is that's exactly why the ratio is a clinical decision and not a coin flip. So shoot for something like bias 50-50 when you want your estradiol to carry more of the load. Now, if you want something estriol heavy, something like an 80-20 when your receptor beta support is your goal, driven by her symptoms, her labs, and what you're actually trying to solve. This objection isn't an argument against combination therapy. It's an argument against doing it carelessly, which is precisely what compounding is for, a formulation built for one woman instead of just 5 strengths of estrogen on a shelf. And I also want you to notice something. The people raising the objection that and are arguing that estriol competes meaningfully at the receptor, which means they're conceding that estriol is pharmacologically active enough to matter. You could tell me estriol is too weak to do anything, or also tell me it's strong enough to interfere with estradiol. So in that sense, you kind of have to only pick one. The fourth objection I hear a lot is cost. I hear compounds are just too expensive. In practice, that's frequently backwards. Once you account for which the patch copay actually runs, and the fact that the compounded cream is concentrated enough for some women that you only have to apply like a quarter or a half an ml daily, I regularly see things like bias, that's the combination of estriol and estradiol, come out comparable and even sometimes less for both estrogens, and then that competes against only just getting the one in a patch. And the last objection is that the blood levels just don't look right. And this is one that can genuinely be a clinical problem, and it's causing women to be told that the therapy failed when it didn't. A patch, it releases continuously. You can draw a level whenever you want to, and you can always see something. A cream doesn't work that way. You have to draw it at a reasonable time window after an application. And I typically recommend about 2 to 4 hours after applying it. So if you check the level 8 hours after she's applied her cream and it looks low, that doesn't mean that the drug didn't get absorbed. It just means you drew at the wrong time. I've watched many women get taken off of therapy that quote unquote wasn't working, all because of mistimed lab draws. And the serum isn't the only thing you can check at times. You can also look at things like urinary, but also salivary testing to tell you things that the serum won't, including how your estriol looks, what she's producing, and also how she's converting it. So here's where I stand today. I want to show you how fast this field is actually moving because it makes a point about anyone who thinks that this is all finished, you're going to realize it's not. I have hormone lecture materials from when I trained years ago, 10, 15 years ago. Good material from serious people in my own professional world. It even said that estriol didn't even have brain protection effects, but a lot of the newer data today is coming out and showing that's changed. 15 years ago, that data wasn't here, but now that data is proven this to be wrong. Every position in this field has an expiration date, including mine. I'll change my mind the day somebody shows me better data, and I've done that before. What I don't want to do is pretend the question is closed when the research is still active. So let me be clear where I stand because I don't want anybody mischaracterizing where I'm at. I am not anti-estradiol. Estradiol is a great drug. It's a great hormone, and it does things that estriol can't. And if you're on it and thriving on it, stay on it. What I am telling you is that the evidence on estriol is real. It's substantial. It spans receptor pharmacology in animal work and human clinical trials. And it's being ignored for reasons that have nothing to do with the science. And that I'm standing on. I've been standing on it for 20 years, and the data is only moved in one direction. So if you've listened to this and you have objection, I want you to bring studies. I'll read them, and unlike some people, I'll read them before I cite them. But if your only argument against estriol is that there's no product to sell, that's not a scientific objection. That's actually a business model issue. So what do you do with all this? If you're on estradiol alone and it's working, everything is resolved and you feel good and you don't need to change anything. And I mean that. This episode is not an argument that your therapy is wrong. But if you're on hormone therapy and your hot flashes resolved while your mood didn't, or your sleep didn't, or you're still dealing with gut symptoms, recurrent UTIs, brain fog, or inflammation that nobody can account for, you have not had the full conversation yet. And here's what to ask. Ask whether your therapy is addressing both estrogen receptors and not just one. Ask whether estriol has been considered. And if the answer is that estriol isn't FDA approved, that's true. Now you know exactly why, and you should ask the follow-up. Is that a scientific objection or is that a regulatory one? because those are not the same thing. And estriol, it's a prescription medication used routinely in Europe. Ask about testing. Serum drawn in the right window at the right time if you're on a cream. And ask about urinary testing, which can show whether you're actually converting and producing estriol on its own, because that varies enormously from woman to woman. And that's the thing that tells you whether a combination makes sense specifically for you. And if you're a provider listening, you don't have to agree with me, but if your patient brings this to you and she's not being difficult and she's not being misled by the internet, she's asking for a legit question about a molecule that her body used to make. So here's the biggest truth from this episode. Your body made 3 estrogens. We replace one, and the one we replace happens to be the one that somebody could sell. I'm not asking you to believe that estriol is a miracle. I'm asking you to notice the reason you've never heard of it has nothing to do with whether or not it works. One thing for you to do this week, if you're on hormone therapy, find out which estrogens are actually in your prescription. Just look, because honestly, most women, they've never checked. And if this was useful, send it to one person, a woman on a patch who's still not right, or a provider who would rather have an argument than avoid it. Studies, all the studies, they're in the show notes. And if you think I'm wrong, tell me. Publicly, I read all of them, and the good ones, heck, I may make the next episode on. And as always, keep seeking the truth about how the body works.